It is my distinct pleasure to invite my co-chair, Professor Borggrefe, and he's presenting assessing the clinical impact of CCM, past and ongoing clinical studies. Martin, please.
Thank you very much, Ulrike. To date, more than 1,000 patients have received a CCM implant, and I would like to review some of the practical aspects in more than 8 years of treatment. There are 2 randomized clinical trials which I'm going to briefly review for you. Both have been published either in the European Heart Journal, and the other one recently by Kadish and Abraham. So the key inclusion criteria for all these past clinical trials were patients with a mean QRS restoration of about 100, so a distinct different heart failure population as opposed to CRT, where the mean QRS restoration is around 140. They had an ejection fraction below 35%, new heart functional class 3 or 4, and required in addition optimal medical therapy. Patients with atrial fibrillation currently have to be excluded because the device is not delivering therapy during atrial fibrillation, and most patients in trials have had additional an ICD implanted. So the first study was a randomized double-blind crossover evaluation concerning safety and efficacy of the optimizer system. And in this trial, like in MASTIC, just over 160 patients were implanted. At the implant procedure, the acute hemodynamic measurement was performed to see an increase in contractility. Then the device was just implanted and healed in, and 2 weeks after running in phase, the patients were randomized into either device on or off, and thereafter, after 12 weeks of therapy, there was a crossover into device on-off and off-on. So in this pilot clinical trial, peak VO2 increases by approximately 1 milliliter, which is very compatible with CRT in the group where the device was switched on and off. However, one also has to explain that there is a significant placebo effect when you implant a device. So initially, all patients improve when you implant a device. And this was a double-blind phase which have never been carried out in CRT patients. In addition, we saw an improvement in quality of life by about 7 points, and that led the company to do a multi-center randomized control trial comparing cardiac contractility modulation in patients with advanced heart failure, and the FDA required to be one group implanted and compared the outcome to that group without CCM implantation. So it's an unblinded one-to-one randomized trial, and there was a 6-month efficacy endpoint, which is a very unusual endpoint for heart failure trials because the FDA requested to use anaerobic threshold to be the primary efficacy endpoint used in that study. The 1-year safety endpoint was composite of all mortality and all-cause hospitalization. So in this study, over 400 patients were recruited. In the group 1, the device was implanted, and then CCM was switched on after 2 weeks run-in, and patients were followed for 12 months and received stimulation for 5 hours per day. And the control group were patients with heart failure in whom mostly ICD were implanted, and the device, the CCM device, was not used. There was a statistical analysis with regard to safety and endpoints. I'm not going into that, but however, we have to recall that with regard to the primary endpoint, anaerobic threshold, there was no difference in control versus treatment. However, in the secondary endpoint, which is more familiar to us using CRT, the delta peak VO2 was significantly affected in this trial. So the cardiopulmonary stress test using peak VO2 met efficacy. In addition, quality of life parameters significantly improved, and you see a delta of more than 10 points in the score. And there was in this study plan, there was a pre-specified subgroup analysis in patients with new heart functional class 3 and ejection fraction above 25%, which was recently published in the Journal of Cardiac Failure. In this subgroup with more preserved left ventricular function, one saw a significant effect on peak VO2 with improvement over time. One also saw that the primary endpoint using anaerobic threshold was met in this patient population. In addition, quality of life parameters in this specific subgroup were improved. I think it's of note that the patient maintains these effects over time, and here you see the treatment versus control group with regard to peak VO2, and within 1 year the treatment effects were sustained. This is also shown for anaerobic threshold. The effect also here was maintained over 50 weeks. You see in blue treatment, in red control. And specific subgroups were defined and depicted out here. These are the results on all patients. This is the subgroup with ejection fraction between 25 and 35, and this is a smaller group of patients with even more preserved ejection fraction. And what you can recall from these graphs, there is a significant improvement in the better patients, so ejection fraction above 25%, and we would, from this data, not to recommend to implant these devices in patients with severe heart failure being candidate for transplantation, because you only lose in these patients. So I would like to summarize the results of that American prospective trial, that the primary safety endpoint was met. In the overall study population, there was an increase in peak VO2 and significant improvements in quality of life, and I didn't show the NUHA data. However, in a subgroup, which included patients with ejection fractions above 25%, approximately half of that patient population included in the trial showed improvements in all efficacy parameters. And the effects were even larger in patients with depressed but even higher ejection fractions above 35%. And currently in the US, there is a study for about 200 patients in which ejection fraction above 25% are going to be enrolled, and just last week the FDA allowed for extension for ejection fraction above 35%. I would like to conclude with one German attempt, the so-called CCM heart failure registry study. I would like briefly to outline the rationale, design, and study objectives. It's a in these data I showed you, there's a positive signal for the use of this device in patients with more preserved left ventricular ejection fraction. And so the primary objective of this registry is to determine the impact of CCN on the composite endpoint of heart failure hospitalization and mortality, because up to now there is no mortality trial available. And secondary exercise tolerance, quality of life is going to be assessed, and specified subgroup of interest are these patients cohort with very depressed left ventricular ejection fraction, patients with 25 and 35 in between, and a more preserved group, and these will be compared to patients, and here you see the study outline, and there will be a case match control study in patients who are not going to receive an optimizer system. We're going to match gender, age, NUHA class, ejection fraction, renal function, as well as stratify for ICDs or CRT in this patient population. So I do thank you for your attention.
Thank you very much, Martin, for this very intriguing and important contribution, because indeed this is at the end of the day what you like to see is whether all this molecular effect they do translate in a clinical benefit, and I think your data strongly suggest that. And I think it's a therapy which does not only fill a gap is an important one, because I highlighted by Professor Hasenfuss, you say is between no therapy, because it's just pharmacological therapy is exhausted, and the other one, which is CRT, which may not be applied or is not applicable, even according to guidelines for many patients. So I think that is something that is also important as a final word, who should not be referred or who has a very less likelihood to respond. And this is also where the boundaries are. So I would say it's quite large. With that, I would like to conclude. Thank you for attending. Thank you to the speakers for this very good overview and very important clinical data.